we talked a little bit about some standards. You threw out some terms earlier about CAMES. Um, what's that all about? Why are all these standards we have to deal with?
Yeah, so as far as getting into standards and accreditation and that sort of thing, CAMES is the Commission for Air Medical Transport Systems. And what they do is they set the standard for the country. And even outside of the country, there's programs that are CAMES accredited. And they set the standard for air medical. So they tell us, hey, this is the evidence-based practice as to how you should be
Doing a thing,
doing
right?
it. Yeah,
right.
It could be as simple as how you put your seatbelt on. They are very very
like regimented.
very regimented to the point. They're even whether it be your aircraft should be set up this way, or you should have your I don't know. They're very to the point.
Yeah.
Your crew configurations. They go into staffing. They go into the time on your shifts. They talk about, and basically it sets a standard for the country to say, hey, we want everybody to be at this high level, and they set that bar for everybody to reach for. So it's important for us to stay at that level.
You got your firefighter analogy keyed up. I feel like there's an NFPA.
Yeah.
We're keying up an NFPA analogy here
Yeah,
on steroids, though.
Just what Kyle said, though, it does. It helps make things equal across the board. It is no secret that air medical, by and large, obviously we're part of the UH system,
right.
But many helicopter systems around the country are ran by for-profit companies.
Sure.
By having CAMES and CAMES standards, it allows especially pre-hospitals and hospitals to know that when a helicopter is landing, they will have a certain level of care and they will have a certain level of expertise, and that a company or a system can't just say, okay, we're going to put a medic and an EMT on the helicopter today, and they might not be able to do what other helicopters do, but it's still a helicopter. It helps keep that standard set. That if an ambulance pulls up to your door, there's at least 2 EMTs on that.
Right.
Per state of Ohio, there's 2 EMTs on that. They could get you where you need to go safely. Yeah, there's variations in care, and there's differences in the care between having 2 medics or having a medic and an EMT. But in general, there is a minimum of what can be on that squad. And it's the same with the helicopter.
No, I think that's a good analogy, because that's clearly become your job on this podcast, is the analogy guy.
The analogy guy. Oh no,
I love it.
In that same vein, you kind of talked to crew configuration. So obviously, nurse medic crew configuration is what we've chosen. There's different models out there.
Yeah, totally.
Just some of the stuff that you guys have experienced or about, and then talk a little bit about the culture between. This is kind of reflective of UH's team, but what is the culture between the nurse and the medic, and
Yeah, so if you look at us today, we're not wearing name badges.
Right.
If you were walking past me and Nate on the street here, which one's the nurse, which one's the medic? You're not gonna know. And that's the way our crews kind of run. We are expected to have the same skill set. We're expected to be able to perform the same duties. We should be able to switch seats. We should be able to do all the same skills together, and we're there to complement each other too. So really, as far as things go, it's a good complement having both a nurse and a medic. But we're really expected to be both at the same level and working at that high level of care.
And I think it's you could generalize one way or the other. I think a lot of people look at a nurse medic crew and they go, oh, the medic's going to be better at the IVs, and the medic is going to be better at the intubating, and the nurse is going to know more medications,
drugs,
and it's extreme generalization, because it's not always true.
Right.
A lot of our nurses are fantastic at intubating, and just yesterday we had a patient. We were leaving the hospital. The patient was an extremely hard stick. And I said, hey, Kyle, go grab an ultrasound and go put that IV in. I could do ultrasound IVs, but he dropped that thing right in like a champ.
Yeah.
So it's like I said, it's a generalization that, like, okay, the medics are going to be good at the pre-hospital stuff.
Right.
The nurses are going to be good at the hospital stuff. It's not always true. I think it does. We complement each other well, and we work enough with each other that, you know, I might be sitting there and I see a patient, I'm thinking medications, 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 and my nurse is thinking more like a medic. Like, they're thinking electrical, okay, let's pace or cardiovert, and I'm sitting there still thinking about medication. So we bounce off of each other, and it results in the best care. Sometimes on scenes, you know, we have our nurses who have been medics or practice currently as fire medics. They're very good on scenes.
Right.
They understand what's going on.
The dynamics and
the equipment, the hazards. They understand all that. And then we have other nurses where they've never practiced pre-hospital. They're very good at the ICU. They're very good at the advanced cardiac. They're very good at that stuff. But if you put them on a scene, they wouldn't be able to walk through a fire truck and say, "Oh, those are the spreaders. Those are the cutters. Those are the airbags. Those are the chalks. Those are the step
Couldn't
chalks."
tell you any of that.
You know, they wouldn't recognize any of that stuff, but the medic would.
Yeah.
So we help each other out, because one day I'm in the hospital and I'm looking at a device, and I have no idea what that is. Kyle goes, "Oh, I've used those 100.
This looks important.
I've used those 100 times." And, you know, it's,
he's over there with his dials, like, "Hey, look, I saw a pilot do this." Like,
yeah, right. And on the other side, you know, we're
twist the knob.
We're on a scene, and you know, your nurse goes to go stick their head in a car to talk to a patient. And you're like, "Oh, don't put your head in front of an airbag."
Exactly, yeah.
I've seen those go off. Don't put your head over there. And so we watch out for each other, and we, especially as you've worked long enough with each other, you start to rub off on each other, and
of course, right? Yeah.
And that separation between the two becomes less and less and less apparent.
I think even some of our, like, getting into that, like, even some of our more senior crews or crews that have been working together for a while, it's almost like we're family. We can work together without saying a word.
Right. It's a glance or a nod or you know.
I mean, me and Nate
or a sigh.
practically know what we're thinking together. Same difference is Nate and Mike working together or something. You know, don't have to say a word the whole time.
Yeah.
Like, you can go in there and we just have a really good relationship with each other, and really you get in sync and you know everybody's patterns, and it makes it flawless.
It's the same, like I said, the years that I've spent on the squad. You have your, you know, if you are fortunate enough to have a permanent
regular partner, yeah.
and you get so used to each other, and they just have to look at you like, and you're like, oh,
yeah.
You don't do trach suction. I got you, buddy. That doesn't bother me.
Yeah, right.
And, you know, or they're going to go load the patient. You look at them and you're like, oh, you don't do nasty feet. The patient's nasty feet. All right, I'll help you out.
I got you.
Everything you just talked about was one of my former partners, and every time he'd be in the hallway gagging the whole time. Yep.
Right. Yeah, you get to know each other. You end up you live and work 24 hours with each other every day, and you get to know how they're acting, how they're feeling. You know, did they eat chili dogs? What are you going to be smelling at midnight after that dinner? And you just get to know each other, and it's
that's when your gas laws come into effect.
Yeah.
Okay, well, you set that up.
Oh boy.
So, you know, some of the specialized testing, we talked about your kind of career paths, how you got here, some of the things maybe somebody who might be interested in working an aeromedical program. One of the things I want to talk about is like the FPC and the CFRN. Tell me a little bit about those tests, those exams, what that means, and.
So the FPC is the flight paramedic test.
Yeah.
And it has to do with a lot of not only advanced medical stuff, because we all think about the advanced medical stuff. Oh, I'm going to be tested on a balloon pump, or I'm going to be tested on an impeller or a ventilator, and I've never ran these things. It also tests you. It will say you're landing. This is your how far you could see, and you have a pair of NVGs on. Can you land? And it's very operational things. The gas laws, Charles' law versus Dalton's law, and it covers all that. There's a multitude of test prep companies out there. I won't spend any time recommending one over the other, but when it comes down to it, if you get into a good program like the one I fortunately was hired into, you're given a length of time to get that.
I understand that.
For us, it was you had to take your first attempt within 18 months and pass it within 2 years. I took it at my 18 months because I got 18 months of the best
hands-on training,
training, on-scene training. Yes, but you could take a test prep course, and you could go ahead and test out on balloon pumps without ever physically putting hands on a balloon pump.
Right.
But you're not really going to understand it. It's at that point you're just memorizing numbers and regurgitating numbers.
Yep.
And I would encourage anyone highly, if you want to get involved in this career field, to get down your basics of critical care, managing the ventilated patient, managing the hypotensive patient, managing the hypertensive patient, knowing your brain bleeds, your pediatric patients, some of the pre-hospital conditions they could have, getting those down, and then go get a job and start putting it into practice. Each program is going to have a different detailed protocol and
orientation process,
equipment that they're going to use. Our ventilator might be very different than another ventilator. And if you're going to be hired to those companies, you shouldn't be expected to have that ventilator memorized. So you need to know your basics. You need to, you don't need to run a ventilator to know how much PEEP a patient should be getting, how much tidal volume average patient should be getting, what the end tidal should be, what a blood gas should be. You don't need to physically see a blood gas printout to know blood gases. That's all the actual pathophysiology and how the patient is. You don't need to see those patients to know those lab values, to know how to treat off of those lab values. There's those rules that you kind of need to go by, and it's best done on the job. But also I understand that there's a lot of companies where getting your FPC is the leg up, the ultimate leg up. Sure. If you get hired with that, it does you a lot of good. But what I would encourage you is, if you got hired, if you went to a prep program, or if you studied a book really hard and you passed that FPC, good for you. That's amazing.
It's not an easy test.
Right, not an easy test.
No, it's not.
That's an awesome thing to do. But now you got the job. Now you got to go back over all that stuff.
It starts all over again.
Yeah, the learning
put it
doesn't
into
stop.
practice.
And,
So
I took my FPC in like 2005, and just to use your points that you made, is tested on balloon pumps, tested on all that stuff. Does that mean that I'm qualified to go run one today? That does not mean I'm qualified to go run one. That's not part of my purview right now, right? So I shouldn't do that, right? Just because I test well doesn't mean that you still have that component of your training has just begun.
I have plenty of letters behind my name. I'm average at best. I'll put it that way.
me too.
And how does the CFRN compare to our experiencing his and I's with the FPC?
Yeah, so they're pretty similar. I think I kind of took a different route with mine. I actually got mine before I got into a transport program. Our area is pretty competitive as far as getting a position in the air medical world, especially with nurses. So having that,
you had to have that.
To
set yourself apart.
It's a real big leg up. So even the programs around here, CAME standards is 3 years or 4,000 hours, and most programs here in this area, whether it be Eastern Ohio or Western Pennsylvania, they require about 5 years. So it's going to be hard to get in, and having those certs and that sort of thing are going to be very helpful. And the testing is all very similar to the FPC. You're going to have all your your balloon pumps and your PA catheters and all that stuff. And like Nate said, you're going to go into your gas laws and Boyle's balloon. So you're flying at this many thousand feet. Should we take the air out of that cuff and maybe put water in it because that's not going to expand?
Right.
So you have to start really thinking about that sort of thing too. But the testing is very similar in that sense. What I would recommend for somebody who wants to get into this position as a nurse is if you can't get onto a helicopter, go to the ground. Get ground CCT experience. I did it.
That counts to the time, right?
Yeah, I did it, and it was huge. In a matter of a year and 4 months, I think I did over 500 some calls. I worked for our program here, and I worked for another small ambulance company. I worked as a Mickey nurse for them, and I got about 100 ground transports with them too. So just having that experience of working outside of the hospital setting with that little bit more of autonomy that the nurses, as a nurse, you're really not used to it, being able to
fair point.
make those decisions as far as, hey, are we going to start a levo drip, or are we going to start an epi drip? Are we going to start a fennel drip? Or, what sedation we want to use considering this patient's condition? Or, so that's things we don't normally do. And even getting to the point of intubations and that stuff, nurses don't do that in hospital.
Part of nursing.
It's not a thing. Right. So that's a huge learning curve. So having the time to go do that on a critical care team and learn those skills and practice those, and even like when I was on our team, you do have downtime there, and we have all the tools to make you successful to train. Mm-hmm. I remember every shift I was on ground, I would go out and I'm grabbing those airway mannequins and we're practicing intubations and practicing weird stuff, and I'm putting them in the back of the truck, and we're doing tomahawks, and we're doing goofy stuff just to see if it works, and it's only going to make you better. So to get that experience on ground is going to make you way more ready for flight.
Yeah, and it's one of those where at that point you're practicing not to be, so you don't get it wrong.
Yeah.
So you don't get it wrong. It's so you can't get it wrong. Right?
Exactly.
You really need to, when you're working towards this goal, you need to know where you're going, but at the same time enjoy getting there, because you don't want to sit there and go to an ICU and work a year and be a bad coworker and be a bad employee because you're sitting there going, I want to fly on a helicopter.
Yeah.
And you guys don't mean anything to me because I want to fly on a helicopter.
Yeah.
Or in my case, you don't want to be, working for an EMS department and be sitting there going, well, this job absolutely stinks because I want to be on that helicopter.
Are you suggesting that fire, EMS, and healthcare in general is a very small fishbowl?
Oh, yeah.
It's very small.
Yeah.
We were just talking about this yesterday.
Yeah.
We had a new coworker, and she was between you two, every single person. We've been from anywhere from Conneaut to Mansfield,
right.
and how do you know everybody in between?
Right.
And we're like, it's very small.
It's a very small fishbowl, and I bet if we
Very
started
small.
sussing out people versus people I know, there's a lot of overlap.
Yeah.
Is that how many degrees of separation for the average? It's far less than
Far less.
far less in fire, EMS.
Yeah.
Public safety.
And sometimes it just takes.
the whole,
Sometimes it just takes one instance of, you could be the best ever.
Yeah.
And you could just have that one bad day.
Yep.
And now you're that person.
You're that guy. Right.
And
I'll,
you're just that person.
I'll 100% credit even getting this job to knowing people. I was one of our riders for our observer program. I'd been out to the base multiple times. I've been at the Medina base, been at the Middlefield base.
They're like, we're tired of seeing you.
Yeah.
Just put the uniform on.
Yeah, right. Like, just get over here. Yeah, and
Either ban this guy or hire him.
yeah,
It was a coin flip.
Yeah, right.
It was your lucky day, man.
yeah. I got pretty lucky.
But anyway.
Yeah, like, and that's huge too, because you can get mentors and that sort of thing, and having a mentor to kind of help you reach your goals and help you set things up to get where you want, and I find that huge. And I had some great mentors. If I could shout a couple names out, would be Mike Boland and Lance Roach, Nate Cleland,
Sure.
Matt Wodarczyk, who's not with us anymore. He's at another program. Those guys were
that Nate Burzitis guy too.
Yeah, Nate Burzitis too.
Everything I ever knew in air medicine, Nate Burzitis.
Yeah, these guys, I mean, I went to them every step, and they kind of pointed me in the right direction and led me the right way. And if it wasn't for those guys, I wouldn't be here right now. And being in this position now, I almost feel that duty to do that with some of the people that I see that are eager and see it and aspiring. And we get these riders at the base sometimes, or I'll talk to, a random person at a PR, and they're like, "Hey, I want to know how to do this. Here's my email. Get a hold of me." And I can coach them through. And I even have a PowerPoint made up with how to become a flight nurse and how to become a flight paramedic. And I'll send them the PowerPoint, and I'll talk them through it. And these are the certs you need, and this is the experience you need, and this is what I recommend for this area. So we'll even get into that sort of thing. Yeah. So I think it's cool to have a mentor, and I think it's important for us to do the same thing as we were.
I think that's very powerful. I'm not, I'm reflecting back on my own career and my mentors early on, and
totally
that is I am very much modeled after some of those individuals.
Totally.
It's just so interesting because sometimes you're dropped off a patient, you're blowing through the hospital, you're redoing your cot, and here comes this ambulance crew with 2 EMTs, fresh out of school, and they want to talk to you, and you're tired, you're sweaty, and you take the time to talk to them.
Smell like Gen A.
Because you remember where you were,
where you came from.
Like and I tell them that I will tell anybody that. It goes faster than you think it will. As an EMT,
it sure does.
You feel like it's unattainable. You're looking at it and going, it's going to take me how long to get on the helicopter?
Yeah.
Like, how do I stay focused for this? How do I stay driven for this? And I'll sit there and talk to them, and I'll say, first of all, it goes by much faster than you think.
Right.
Because if you're like me, you're going to have fun at every single level that you work at.
I think
you're going to enjoy it. And at the end, you're going to be at the place that I am, and you're going to be looking back at somebody like me who took a moment to talk to you. Yeah. And I hope you take that moment and talk to somebody else. When you're the medic, you're talking to the EMTs, and you're encouraging them, in education and experience and good job practices and treating the patient right. And when you get to that next level, you're looking back on where you were and the people who are looking to you as an example and encouraging them the same way. Say, it doesn't change. You treat your patient right. You treat them with dignity. You practice your medication safely. You do the right thing every single time. And it's just a building. And it's funny because, like I said, I could look back at the people who mentored me. And I'm like, I was the skinniest little EMT in my, inter-facility transfer uniform. Just brought the guy, taking the guy back to dialysis. And I'm sitting there like, oh my goodness, I just talked to the air crew, and they knew me by name because I talked to them last time. And you never, in that moment, when you look at all the years it takes to get there and the experience it takes to get there, you're like, there's no way I'm going to be standing there.
Oh, people look up to basketball players and baseball players and musicians. I remember looking up to these guys, being like, oh, they work on the helicopter, like they were they were the celebrities to me. So to be here, cool. It's surreal.
What were you going to ask, John?
I would say to your point, I think about it's a long path, right? It's years to get on that aircraft, but don't go into it of, man, this is just my stepping stone to the next thing, but take that experience that you're running on EMS or pre-hospital care or as a nurse to be like, how often do you use your knowledge you gained in the cardiac ICU on your flights?
Yeah, it's huge. That's massive. And I think if you can take every learning opportunity you can and run with it, it's a huge thing, and it's only going to make you better in the future. So don't take that for granted at all if you're trying to get here. There's always something to learn from somebody.
Exactly. Yeah. Even if that's, and I have an experience.
Even if it's what not to do.
Yep, beat me to it. There are mentors in good and there are mentors in bad, and we have both.
Yes.
So I looked up a quote earlier, and now it's going to bring it up. But only a fool learns from his mistakes, but the wise man learns from the mistakes of others. So learn from the mistakes other people make, learn from your
Yeah.
own mistakes,
Right.
be humble in making those mistakes, or own those mistakes.
Yeah.
Yeah.
And then take everything you can. Oh, hey, can I help with that procedure? Can I what can I do to help with this? Oh, how do you want this set up? I'll help you set
Hey,
up.
show me
Totally.
Yeah.
Yeah.
that. Hey, show me that. What
Yeah.
are you doing?
I love it.
Always be asking those questions, and I think that's something. You think of being young as a practitioner, and that is when you're asking all the questions. But that's back when I was too scared to ask the questions I should have.
Yeah.
Now I walk in and the doctor says to me, "Hey, you're the nurse for room whatever. We're going to be putting in a chest tube." And I sit there. I'm like, "Well, I've not worked with you before. This is my first shift with you as a doctor. What do you want for your chest? Pull out a piece of paper. What do you want
What
for
do
your
you
chest
need
tube?
for- yeah,
What
yeah.
size?
Yep.
Do you need anything special? Do you need use a certain scalpel? What kind of setup do you want?
Yep.
Do you have any special requirements for what kind of suction we're going to put on it? How do you want it secured? What do you just it's not
What do you want for
when-
the local? Yeah.
right when you see somebody doing those questions. That's somebody who has
That's baked in experience.
not
Yeah.
done it before and fallen on their face in not a good way,
Right.
and have been caught holding the bag, so to speak.
Remember my last chest tube?
No.
You either just
That was
got
Kyle.
invited. Come on. I was gonna say you either just got invited to his next one or uninvited from his next one. I'm not
Right.
sure. Which.
I mean, as you get used to working with somebody like a partner, and I know, when Kyle intubates, he wants this, and this.
yeah, right.
And we've intubated enough patients together that I'm like, oh, he likes this stylet, not the bougie.
Yeah.
He likes
He's
this
he's
style,
a hyperangulated
right.
guy, or he's not.
Yeah.
and
or
you get
whatever,
used to that, and it's the
Right.
same thing when you're working with a doctor or a
Right.
provider. And
course.
there's
Any level provider.
right, there's
Right.
there's
Exactly
there's
right.
certain doctors where they walk up to me and they say, "I'm putting in a chest tube," and I'm like,
Yeah, okay.
"Cool, your
Give-
stuff
yeah,
stuff will be in there. I've done it enough with you.
Give me 2
We're
minutes,
great."
right? Yeah.
And it works that way. But
I'm surprised you didn't say it's already set up. I'm waiting for you.
I put it in for you.
yeah,
Just
but
sign here.
as a young clinician coming up, that's something I wish I would have done more.
Yeah.
Instead of having your medic getting frustrated because they're like, you knew I was starting an IV. Why didn't you spike a bag?
Right.
Instead of doing that, I would have been asking those questions like, okay, you're going to be starting this IV. Are you going to be running fluids?
Yeah.
Yep.
Yeah, I'm going to be, okay, I'll get the bag ready for you.
Do you want to flush? You just want to hook it, or
Right.
do you want me to spike a bag and I'll just hand you the line?
Exactly. Are do you want
You giving a lot of volume, or are you just gonna TKO it? What are you doing?
right?
Yeah.
And to ask those questions before you're going into it, even when you're going into those situations where you're extricating a patient.
Right.
Are you going to be the person who's just like, well, there's stairs, so I'm grabbing the stair chair? Or is the partner sitting there going, no, they're 10 years old. I think we're gonna
Not piggyback them.
We're not gonna put this tiny little person in a big stair chair and
That weighs
hope
more
for
than
the
they do.
best.
Yeah.
And so that talking and asking questions kind of comes back to the whole mentor thing that we were talking about. Is your mentor is only going to be as good as the questions you ask and what you observe from them. If you are the type of person who just walks in, and it could be the most experienced, nicest mentor in the whole world, but if you're not willing to ask the questions,
Yeah.
and if you're not willing to listen to the answers, it's a
Also
waste of
fair.
a good person on both sides.
Yeah.
I'm gonna jump into this because this part of this conversation is making me really excited. So
Triggered
I've gotten,
or excited?
What's that?
I said triggered or excited.
No, excited. So I've gotten the opportunity to work in the capacity of, per se, a clinical training officer, field training officer,
Yeah, absolutely.
and train some of our newer paramedics and nurses and that sort of thing that have come on the team. And with the mentor thing and asking questions, I love that you brought that up, because one of the things that I tell every single person that comes and rides and orients with me, and I even told our new orient yesterday because it was our first shift together, I tell every single person, I don't believe in stupid questions. I am here to support you. I want you to ask me as many questions as you can. I want you to ask me, if you think it's the silliest question in the world, still ask me. Because at the end of the day, you want to know the answer. I want to give you the answer. I'm not going to laugh at you. I'm not going to make fun of you. I'm going to support you because, when push comes to shove, me and you are going to be in the back of that aircraft, and it's going to be me and you, and that's it. And I want you to feel confident, I want you to feel comfortable, and I want you to be the best that you can be. And that's where I want you at all times, and I mean that's huge for me. So as a mentor, I think that's good for looking for somebody that's kind of supportive like that too. 100%.
In my personal evolution as a provider, teaching has been a huge component for me, right? Because it's like, yeah, I know it, but then to have to explain it, and then
different level of understanding.
It's a different level of understanding, and what you don't realize is how much stuff like I have synthesized for myself, right? Without somebody, just by trying to explain to somebody else, I'm like, oh, all those things are interrelated, right? Or whatever the topic is, right? Oh no, oh, there's more to this, right? Or I realize that I only know this superficially, and I need to go back and do a deeper dive on something.
Yeah.
That's been a huge part of my personal evolution. Just as we're talking through some of the psychodynamics of of operating as a high functioning team, right?
Totally.
But one of our last recordings, we were talking about crikes, right? I did something I probably should talk about that I didn't, and he picked up on it.
Oh, yes, yeah.
I was stabilizing my hands on the patient when I was doing my crike. I didn't say it out loud.
Yeah, he put his dominant hand, he anchored it and was doing this. He wasn't doing this, right?
Yeah.
But I didn't say it out loud.
Yeah.
When I teach patients about when I teach other doctors to do like central lines and procedures, I talk a lot about, hey, anchor your hand on their chin. Anchor your hand here so you move with them. I didn't realize I was even doing it when I was talking about crikes. So now I have to go, when I teach about crikes, like, hey, make sure you anchor your hand on the patient. So if you're right in the back of an ambulance or an aircraft and things move, you're moving with the patient.
Oh, yeah.
You're not just stabbing him in the chest.
Right.
All of these misses, but that's the one I wanted.
It's the whole general principle. When I leave here, I don't have to map my way home. I know my way home.
Yeah, right.
But I'm sending you to my house to go get something, and now I have to explain to you how to get there, how far you're driving, and what names are the streets, and that's a whole lot different.
How to get in.
It's a whole lot different.
No, it is. But I just think of how many things that I have, just brought together as part of me explaining it to somebody else. I'm like,
Is the second dose half, or is it the same,
same.
or is it double?
Honestly, but I don't want to belabor this, but the other thing it's done for me is it's made me understand a lot of very complicated things simpler.
Yes.
And more actionable real time, right? There's a saying, it's hanging in my office, like the faster you categorize unimportant things as unimportant, the better you'll do at any particular thing, right? And so you learn, synthesize things down, compact it down. Everything else is just fluff, right? It's like National Registry, when we test out, it gives us all this stuff that we have to regurgitate back, and in any given situation, what's really important. But anyway, I didn't realize psychodynamics was going to be a huge point here.
Yeah.
But this could be its own standalone podcast, right? Let's talk. We'll kind of start towards wrapping this up here. Let's just talk about some of the special things that an aircraft might bring to a scene.
Cool.
That I might not have as a ground ambulance provider. So,
or even a freestanding ER.
Yeah. So
that's
a great point. Yeah.
I think the most important thing a helicopter brings to either a hospital or to a scene or anywhere is it brings 2 extra set of eyes to look at a problem.
2 extra eyes, 2 and 4 hands.
And those and ones that have seen a lot.
Yep.
They have the experience. Obviously, we got the job. We've passed the test, so to speak, and we could provide the skills, and we could provide that extra set of hands, that extra set of eyes, and that hopefully two whole brains at the time. So,
or at least 2 half brains
to put together
to make one.
Right.
Because
mostly functioning.
You could have all the equipment in the world. You could roll an entire school bus full of equipment up, and if you don't have all the hands on board and all the brains on board, it doesn't mean much.
Right.
That being said, we do bring a lot of extra
Well,
tools and equipment.
Yeah,
so.
and let's evolve that into just that discussion.
Yeah, so our aircraft.
What about the tools, right?
Let's look at that aircraft. I mean, it's
As a tool, yeah. Fair enough.
The best thing, I mean, the coolest thing about that aircraft is we're a moving ICU.
Yeah.
We bring a lot of stuff with us. We bring IV pumps. We bring portable suction, which you're going to have portable suction and IV pumps in a regular ambulance too at times. But then we're bringing our ventilators, and we have some pretty high quality ventilators.
No, they're pretty
with our
cool.
Hamilton T1s. We can
they're
do
pretty cool.
pretty much everything with them,
You can.
even including high flow nasal cannula and some of the crazier vent settings and that
The
sort of thing.
exotic vent settings, as I
Yeah.
like to call them.
Oh, you could get down the rabbit hole. We could make
We could make a week series on some of that.
100%. And then as far as any other equipment goes, I mean, we carry a little bit of everything. So we carry about 70 different drugs, including narcotics. We have inotropes. We have our vasodilators. We have vasoconstrictors. We have medications for vomiting, for a number of things. I mean, we could talk about this all day too, and all our drugs that we carry and what we can use them for. And
Everything.
Bleed, you can make them stop bleeding.
Yeah.
Everything from paralytics to antibiotics.
Yeah,
fair enough.
Yeah,
right?
we got a little bit of everything. So we carry all that stuff. Like I said, we have our pumps to give all those meds. A really cool tool that we carry is blood. We carry 2 units of packed red on every flight, and super beneficial, especially for some of these trauma patients. And I've seen it numerous times where, it's saved somebody's life.
Are you suggesting that normal saline still doesn't carry oxygen?
I'm not a big fan of the pasta water. But
Even if you add food coloring.
Stale pasta water.
Yeah,
still
not my
doesn't
thing.
still doesn't carry oxygen, huh? Well, I keep hoping.
As far as the blood goes, there was a study out recently. I forget exactly where it was published, but it talked about pre-hospital blood administration,
blood, right.
and I believe it was in an urban setting. It was actually, I think, a city that was using it, and they talked about prepping your patients for intubation. You set them up, the study showed a drastic improvement to where they didn't even have to tube patients because they were giving this blood, and their mental status improved and their GCS improved.
Didn't have to take the airway.
Yeah, so they didn't even have to take the airway. These patients just got better, which is excellent. And that's a huge tool for us as far as,
That's the goal, is to win right there. Yeah.
We're preventing all kinds of complications from happening.
Exactly.
I mean, no number of things could get down the rabbit hole on that with tubing a patient and what could go wrong. But, I mean, we're helping in that sense. We're helping with hemodynamic stability. That patient that just was in the rollover car accident that's bleeding in their abdomen, those 2 units, that's enough to get them to the hospital, get them to the OR, and that saves their life. That's huge. So to have that in our back pocket it's massive.
Well, from the hospital trauma side, I brought this up before, is like there's a huge swing away from the crystalloids to the max of one liter total.
Yeah.
And if you're still not getting improvement, it's blood. Because they're bleeding, right?
Yeah.
They're losing blood. Replace it with blood.
It's taken us all this time
I know.
to go, the red stuff needs to be inside.
Not even is that blood just beneficial for your trauma patients. We can get into GI bleeds there, Mr. Rositis. Me and this guy probably had one of the worst GI bleeds I've ever seen in my life. And, we got out to one of our ERs, that smaller ER. They're actually closed now. It was Bedford. And they only had 2 units of blood in the hospital. So for us to bring that blood,
doubled their
with us-
capacity.
we just doubled their capacity, and we got that patient to the MICU, where, if we didn't have the blood, I don't think they would have made it. It was that bad. So that was huge for that patient. It probably saved their life.
I had a septic GI patient. I flew out of Richmond because there's no other transports available. I said, send the helicopter.
Yeah.
The blood bank didn't want to I'm like, I need blood and I need the patient out. Like, they're way too sick. I'm intubating as I'm on the phone with the ICU. They're like, what's going on? I'm like,
A little bit.
their blood pressure's this, their heart rate's this, there's blood coming out of their rear end, and they're crashing in front of me, and I'm trying to put a tube in. Flight will be here in 5 minutes. Okay. Thanks. They lived.
That's awesome.
Yeah, that's some of the other things that we could do are a little bit more in the way of procedures.
Interventional stuff.
So I know video intubation is pretty widespread. But if you don't have that, we have
You're
that.
bringing
We
that
have
to 'em, sure.
very good quality video intubation.
Absolutely.
We bring the NG tubes. We bring the OG tubes.
Mm-hmm.
For our nurses, the medics aren't allowed to do it at this time. But
That's a state of Ohio thing.
yeah, if you're decompressing a chest and you are not getting the results that you need, or if the patient is a trauma arrest, our nurses have a cool trick for you.
Yeah, we can do finger thoracostomy, and that's more definitive than putting that little 14 gauge needle in there and hoping that it doesn't clot off and keep the air out.
Pencil
we
lead,
can we can take a little scalpel and make a little cut and open that up. And
Unless you have 14 gauge fingers.
yeah, I mean, yeah, we can open that up. Had the opportunity 2 months ago to do one of those on our rooftop. We had a patient who was decompressed 5 times in an accident, and we came to the conclusion that this is pretty futile, and really I was sitting there watching our ventilator, and our static compliance was decreasing, and watching our pips and our plats go up, and it just didn't look good. And at that point it was, hey, we're going to do this. So we ended up on the roof and grabbed the scalpel out, listened to the lungs, and could tell that there was nothing on the right side. So we cut and instantly got the air out.
Got your finger in there, got a bunch of air out.
We watched the blood pressure go up.
Yeah.
We watched their oxygenation get better. It's an awesome procedure to have in our back pocket.
Yeah, for those of you who are not familiar with the procedure, it's a chest tube without a chest
Without
tube.
chest tube, right.
Yeah.
That is simply what it is you are able to open up a rather large hole,
Vent them
out, and get a lot of blood and air out of there that might not pass through your
Standard
decompression
14
needle.
gauge.
Yeah.
It's amazing, even on a trauma arrest. Had an opportunity a little over a year ago with one of my other partners, and we got there and they were prolonged extrication over an hour. We got on scene and got in the back of the squad, and they were doing CPR. My partner passed the tube real quick, and I bilateral finger thoracostomy this guy, and we actually brought him back. It was pretty amazing.
Wow.
So to have that tool to be able to fix them that quick and see the improvement, it's cool for the patient. And it's cool for us to get that instant gratification.
Right,
too,
sure.
Hey, we just saved that guy. So definitely.
Because you went from, we probably weren't going to fly this guy because he's in cardiac arrest, to oh my, this guy's potentially salvageable now.
Yeah, he's back, and we actually ended up flying him. So
wow, that's a cool case.
So back to the fireman example, right? We're talking about diameter of hoses for flow. You can only pass so much air or fluid, right? Air and water, they're all fluids, through a 14 gauge needle, which is really small.
14 gauge is huge.
Yeah, I mean, would you rather...
From a resuscitation standpoint, but
From
I
a
still
fluid
put in... I put in cortices that are much bigger, as opposed to your finger, or a 36 French chest tube, which is about the size of a finger.
Yeah,
That's
absolutely.
what you need.
When it comes down to it, what would you rather drink your milkshake through?
Yeah, coffee stir.
A big straw or a coffee stir?
Yeah, right. Yeah.
You know, you're not going to get much out of that coffee stir.
I'd like to see some people drink a milkshake through a
that was
coffee
a good
stir.
analogy.
Yeah. Guys, this has been awesome. Thank you so much. We've spent a lot of time on this, but there was a lot to suss out here, and I appreciate you guys getting here and after all the shifting around and finally getting this done. This is huge. So.
It's been fun, definitely.
Yeah. So.
Yeah, I'm sure we'll be walking out the door and we should have talked about this too. So
well,
always how it goes.
Wouldn't it be great if you would write those down and we'll solve those problems on the live show?
Yeah. Can we call it From the Air to On the Air? It would be a great name for the episode.
Now you have a second job.
I'll be curious to see what questions other people have for us too.
No, that'd be fantastic. I would be very
I would love
interesting.
to hear what people have to say, and be able to clarify some things, or maybe give somebody a good answer.
Yeah,
definitely.
I'm just here for the comment section. Bring it on.
Here for the analogies.
No. You're on the receiving end of the comment. You're not supposed to be giving them. He's gonna be sitting here texting the whole time.
I like reading them. I like reading them.
That guy's handsome. So, guys, thank you so much.
All right, thanks, Scott.
Thank you.
Thank you, Dr. Hill.